So on behalf of Thalassaemia International Federation, co-organizer of this webinar, I feel very honored to welcome you all and to thank Thalassaemics India and our friend, collaborator, long-term collaborator, Mrs. Chuli, Vice President of Thalassaemia International Federation, for all her contribution, as well as Thalassaemics India in general and Thalassaemia Patients Advocacy Group for co-organizing this webinar. It is my pleasure to welcome the national and international experts on the panel of this webinar, to which more than 500 participants are registered, to express our gratefulness and appreciation for their time and allowing us to share knowledge and experience on this topic, which concerns advances in the care and cure of thalassemia. Allow me to particularly and especially welcome Mrs. Venita on behalf of the Indian National Health Authorities, who's always with us with a great focus on developing policies for the medical and other care of patients with hemoglobin disorders in India. And Professor Konstantina Polidis, who responded on a last-minute invitation, honoring during these days, as you know, 14th of June is the International Day for the Blood Donor, and we could not have a webinar without paying even a brief message honoring the Blood Donors Day. Thank you, Professor Hoxha, Vic, Antonio Piga, Regina Grosse from Germany, and the national experts, Professor Talika Seth, Professor Alok Silvestana, and of course our patient advocates, the representative Dr. Samena Santara. So, just the last kind request, because in the interest of time and aiming to share all the knowledge and experience we can get from our national and international experts, please, the participants should have their should be on the muted mode so that we can have no delays and problems on the webinar technology. So I give the floor now to Mr. Deepak Chopra, who's President of Thalassaemics India, for his welcoming. Before I give to the moderators, Dr. Khanna and Dr. Amita Mahagana, the floor. So the timing is in the hands of the moderators, and thank you very much for your attention and for giving Thalassaemia International Federation once again the opportunity to conduct this webinar. Again, muted microphones, please. This is a warning from my technical director here. Muted for all, on the muted mode. Thank you. Mr. Chopra.
Can I start, please?
Please.
Can you hear me?
Very well.
Well, namaste to all of you, because I know that there are participants from 27 countries where there is a time zone difference. So somewhere it should be afternoon, and in India, we are heading towards the evening. This webinar technology has come in very handy post the COVID situation world over. I think if TIFF or Thalassaemics India and TPAG were to hold a seminar in any of the cities in Asia, maybe participants from 27 countries would not have been there. So this is all thanks to COVID that such a situation has been created where more and more participants can take part and deliberate on subjects which are of utmost importance. as far as this webinar is concerned, you have selected a theme as advances in the care and cure of thalassemia, new hope and challenges. I pick up two words out of this entire theme. Firstly, care, and secondly, challenges. I don't know as to what should be the situation in other countries, especially countries from where participants are participating in this webinar. But I can only throw some light that the word care and the dimensions of care for thalassemics in India have undergone a 360-degree turn since the COVID. The norms which were there pre-COVID, the thoughts which were there pre-COVID, and the plans which were there pre-COVID have found no place today, as there are firefighting issues which are taking place as far as the care of thalassemics in India is concerned post-COVID. If I pick up the second word, challenges, I know if while preparing for this webinar had very high standards in mind, but unfortunately the challenges for thalassemics in India post-COVID have taken, as I said, a 360-degree turn. Patients in India today are not only fighting COVID, but are also fighting for blood donors and for blood transfusion. So from the Indian perspective, these two words, care and challenge, have a very different dimension. I am sure that the experts and the panelists who are going to deliver their thoughts are going to keep these highlights, as I have pointed, in mind, because the care and challenges for patients in India could be quite different to the care and challenges of thalassemic patients in other countries. Our co-host from India is our patient's body, which is known as the Thalassemic Patients Advocacy Group. Now, many of you may be aware that this group was created about 3 years back, and it is an attempt to leverage the collective and unified voice of empowered patients and experts to protect the overall interests of thalassemics and prevent thalassemia in India. The model is unique. It is run by approximately 40 patients who are professionals and experts in their own fields and are spread in all the 4 regions of the country. The objective behind having this body known as TPAG was that there cannot be a better submission and presentation than the patient himself, because the needy only knows the need. The carer can only provide the care. I am glad that Dr. Soumya Santra from the TPAG, who's also one of the speakers at this webinar, is going to highlight issues which are confronting the TPAG so that participants and other panelists can understand as to what is the need and call of the day. I am obliged to Dr. Andrula from TIFF, Professor Politis, who's going to speak on global blood safety, Vanita Srivastav from our own city, Delhi, India, who's going to give the Indian perspective, Professor John Porter for the gene therapy, Professor Vipra, who's going to talk on hope for these thalassemics, on Rebizol, our age-old friend, Professor Piga, Dr. Gross, Professor Tulika Seth, Professor Alok Srivastava, and needless to forget, Dr. Khanna and Dr. Amita Mahajan, who are the saviors for thalassemics in Delhi. My able colleague, Mrs. Shobha Tulli, as per the drawn-up program, is going to deliver the vote of thanks, and I'm sure she will add up some of her thoughts while concluding the webinar. I now throw the floor open to the moderators for the next session with a hope that the areas of care and challenges of Indian perspective would be kept in mind, because as far as I am concerned from Thalassaemics India, the challenges and care for these thalassemics post-COVID has taken a very deep turn. Thank you very much.
Very much. The floor is for the moderators now. Thank you.
Thank you, Dr. Andrula Eleftherio and Deepakji. I am joined by my colleague, Dr. Amita Mahajan, to conduct this program. She is a senior consultant in the Department of Pediatric Hemato-Oncology at Indraprasth Apollo Hospital, New Delhi. Today we'll have the privilege of listening to the masters in the field of thalassemia who have spent years, or should I say decades, working on and for thalassemia and have conducted research in this field. To make this program successful, I hope all the speakers will adhere to the time allotted to them. And for the participants, I just want to inform them that we'll have a question answer session after all the deliberations are over, and they can write their questions in the chat box. Now we start with our scientific program. You will see the program is in two parts. One is in the honor of Blood Donors Day. You see, 14th of June is celebrated all over the world as World Blood Donor Day. We thank all our blood donors for their precious and life-saving gift. And in this session, our first speaker is Professor Constantina Politis, who is head of the Hellenic Coordinating Hemovigilance Center at the National Public Health Organization in Greece. She'll be speaking on the global perspective of blood safety. Dr. Politis, please. Can you connect to Dr. Politis?
You have got my...
Constantina Boledi.
Dr. Constantina, please unmute your microphone, please.
She's speaking, but nobody's on.
Unmute your microphone, please. Sorry.
Can we have her on the screen? At slides?
Slides, her slides.
She's talking away. Yes, yes.
Better now? Can you hear me now?
Yes.
Yes, madam, we can hear.
Okay, well, thank you again for the invitation in this very important webinar. And I'm very honored to stay with you and try to give answers to questions from patients. Apparently, the topic of my presentation is blood safety, which with quality of blood components is a really primary focus for everyone involved in transfusion medicine. And this is why intergovernmental, international organizations like WHO, Council of Europe, European Union have issued recommendations, resolutions, directives, and guidelines, as well as regulations to ensure safeguarding blood safety. However, despite all this and the efforts to safeguard blood safety, we know that contamination of blood components from donors infected with the so-called emerging infectious diseases represents a very significant threat to the blood supply. Now, there are four major pillars safeguarding blood safety, and the first one, so I'm talking about the four major pillars for safeguarding blood safety, which are: one, it is the selection of blood donors and testing of donor blood for transfusion transmissible infections, including viral infections, bacterial, parasitic, and other. The two is blood grouping and compatibility, blood processing and storage, as well as epidemiological surveillance of adverse reactions and adverse events in donors and in recipients, and that is the meaning of hemovigilance, for close monitoring throughout the vein, the chain, vein to vein. Which are the key components now for safe and adequate blood? The basic and most important is voluntary, non-remunerated, regular blood donation. Second, screening for infectious markers. And third, evaluation, monitoring, and hemovigilance programs supported by governments and competent authorities for blood and hemovigilance. Now, in the next few days, we are celebrating the voluntary non-remunerated regular blood donor. Blood donation in this matter represents the cornerstone for blood safety because it ensures the lowest possible risk of transmitting infections, thus contributing to the prevention and the protection of human health. Is it the case in all of the countries? Well, actually, I was putting the question to myself and to ourselves, is the voluntary non-remunerative regular blood donation the case for all of the countries? Of course not. And we know with the surveys of the WHO, particularly the Global Status Report on Blood Safety and Availability of the year 2016, stating that only 74 countries collect more than 90% of their blood supply from voluntary, non-remunerated, non-paid blood donors, and 72 countries collect more than 50% of their blood supply from family, replacement, or paid donors. So this is an important burden, and many countries are really trying hard to change the situation and try to increase the regular voluntary blood donation. As regards now screening for infectious markers, blood safety is determined by the efficient detection and removal of infectious blood units from the blood supply. And for this purpose, quality assurance and standards for blood screening for infectious markers determined by official regulations and legislation are essential in the countries. We know that currently the minimum mandatory screening tests for infectious markers are relying on serological methods, and in some countries on molecular methods. The tests, which are almost everywhere applied, are the antigen for hepatitis B, the anti-HIV antibody, anti-HCV antibody, and syphilis. Now, in many countries, but not all of the countries, anti-HTLV1 and 2 and anti-BHB core are tested on account of better defining their mandate for screening. Now, the nucleic acid screening for HCV RNA, HIV RNA, and HPV DNA represents the state of the art in many countries and has really increased blood safety very, very significantly. I'm afraid this is not the case for many countries, many countries around the world. And this is something that we very frequently discuss in the meetings and the international seminars and congresses organized by TIF. Now, I would like to stress another point about blood safety, and this has to do with the need for applying more stringent blood safety measures, including blood testing for other infectious markers, depending on the epidemiological situation in each country, or in support of transfusion of highly susceptible patients. And I give some examples for the patients who are really on the screen and like to know: cytomegalovirus, West Nile virus, malaria, dengue, Zika, Sanders, and other infectious factors. I here would like also to say that according to the estimations of the WHO, we know that as regards the vector-borne diseases account for 17% of the estimated global burden of all infectious diseases. Now, the programs for evaluation, monitoring, and humovigilance are very important too. And in Europe, we have established national humovigilance programs that they are performing epidemiological surveillance of transfusion-transmitted infections in donor blood and detection of infectious and non-infectious risks of transfusion that are helping to guide and to monitor the testing necessary to maximize the blood supply and cover all activities within the vein-to-vein transfusion. In this context, the post-donation and post-transfusion information are essential and specific humovigilance procedures for tracing of recipients of potentially infectious blood donations. I'm sure you all know that in European Union and generally in Europe, both European Union as well as Council of Europe have established legislation imposing countries to have and to develop national hemovigilance systems for the purposes I have already mentioned. In the next slide, I'm just showing a diagram indicating the measures for protecting the blood system in case of blood-borne diseases. That this is the case in so many countries. Hemovigilance measures for the affected areas and many measures in unaffected areas for the protection and for ensuring blood sufficiency. Now, a few words about the factors for transfusion transmission in the recipient. The frequency with which an affection is transmitted depends on three factors. One is the length of an asymptomatic blood-borne period. Two, how often blood is donated during this period. And three, on the immune status of the recipient population. If you think of thalassemia, we know very well what I'm saying. So factors relating to the infectious agent and to the genetic and immunologic makeup of the recipient will also determine the frequency and the severity of the disease resulting from the infection. Just, I would like to stress the use of the right blood component at the right time for the right patient, leukodepletion, prevention and monitoring of bacterial sepsis, accurate cross-matching, and antigen and antibody screening to prevent alloimmunization and gamma irradiation if required. The new advances is pathogen inactivation of red cells, molecular immunohematology advances, and barcoding and computerization. And in conclusion, I just like to say that risks and threats will always continue to exist despite the tremendous progress. So laboratory tests may fail to identify viruses during the window period or because of imperfect sensitivity. And the clinical significance of newly identified infectious agents is not always completely clear, and donors are not screened for these agents. Newly emerging infectious agents such as coronaviruses, high viral and influenza strains, prions, and other may continue serious threats. So advanced absence of widely accepted or routinely used tests for bacterial, viral, and other pathogens is a very important issue. I leave the question which I'm sure is in your mind and in the mind of the patients about the threat of COVID-19. And I leave it later on for the patients to give me, to put questions. And if you want me to just say in 1 minute a message on this, I may just
yes, madam, you can give the message, no problem. No problem,
right.
madam, you can convey to them.
There is no evidence at all that COVID-19 is transmitted by blood. It's the same as with all other respiratory viruses. And this is a very important message, especially for the multi-transfused patients with thalassemia. However, COVID is a tremendous threat for the blood supply, the maintenance of good health of the personnel of blood transfusion services, and for the society in general. So the emphasis is not put in this issue on the blood safety, but on the blood adequacy. Thank you very much for your attention.
Thank you very much, madam, for a very informative talk. And the message that you gave that COVID-19, there's no evidence that it can be transmitted by blood transfusion. I know it's a very vast subject. It cannot be discussed in 6 minutes only, but we had time restriction. Thank you very much, madam. Now to present the Indian perspective on blood safety, I invite Mrs. Vinita Shrivastava. She is a National Senior Consultant and Coordinator of Blood Cell in the Ministry of Health and Family Welfare, Government of India. She has been the force behind improvements in the transfusion services in India. Mrs. Vinita Shrivastava, please.
Yes, sir. Dr. Khanna, I'm here.
Yeah, please start.
Actually, the presentation is with Mr. Revat. He has to start because they were not able to share the screen actually.
You can you continue without that, and in the meantime he'll set the screen.
So that will be better. I'll put up my presentation here and we'll talk about that.
Yeah.
So you can see that when we talk about, I mean, first of all, very good evening and greetings from Government of India. We understand from the Government of India's perspective that blood is an instinctive requirement of health and proper care functioning of the health system. Now, when we talk about the health system, it is maintaining the blood supply for the peripheral areas, which is very important for the Indian perspective. Maintaining a safe supply of blood and blood products has become a national priority in many countries as well as in India. And we understand that here in India, the human blood is regulated by Drug and Cosmetic Act 1940, which in turn directly impacts the blood services. As my previous speaker has talked about, that developing countries account for 80% of the population, but contribute only 40% of the global blood supply. And more than 60% of the blood supply in the developing country is collected from wall donors and plate donors. So this is very important when we talk that this is the cost of this blood, which is incalculable cost. And it is very important that we have a very good, safe supply. So we understand that human cost of unsafe blood is incalculable. Morbidity and mortality resulting from the transfusion or inflooded blood have far-reaching consequences, not only on recipient themselves, but also for their families. So concerns when my earlier speaker were talking about the recipient, the first thing which comes to the Government of India's mind is that the recipient should be safe. When they get the transfusion, it should be safe. Shortfalls in blood supply have a particular impact on women with pregnancy complications, trauma victims, children with severe threatening anemia, we understand. And globally, what we have in India, I'm not talking about the global because just now we have the global perspective together. And 45,000 women die every year in India because of the postmortem hemorrhages. So it is important that we have to understand that the safe blood supply is pretty important to Government of India. So when we talk about how to go ahead with the blood services to have a safe blood supply, we understand that unavailability of blood in many times may cost lives. So access to safe blood is achieved by narrowing the gap between the demand and supply through motivation, recruitment, retention of voluntary non-remunerated blood donors, and by ensuring quality practices, which is very important. When we talk about, earlier my speaker talked about the 4 pillars. The first pillar we say that it is the voluntary non-remunerated donors, which are the basic cornerstone of the blood services. Then second thing which comes is the quality practices, which is very important when we are checking with the viral infections, TTIs. So important that they are being taken care of. And third is how to improvise these services in the periphery level. So the vision is to provide safe and quality blood to every patient in need of transfusion in the country through a well-coordinated blood services. That is the concern. And the key task is to modernize blood banks in the country. We have a blood bank in each and every district of the country, and we need to modernize those blood banks. When we talk about modernization, that means automations, the molecular testing, the blood grouping part, which should be automated. So we are planning to have those things. And the previous slide, please. Mr. Revat, the previous slide, please. I was on the 5th slide, actually. The previous slide,
Yeah, this is the fifth slide, madam.
Yes. The screening of blood and blood products for TTIs, promote voluntary blood donation, ensure safety of recipients. The most important task is that the first 3 tasks have been achieved, and then only we can take care of the 4th task, that is to ensure the safety of the recipient. Next slide, please. So the program, next slide, please.
Yeah, this is the 6th one.
So the program strategy, you can see, the develop and strengthen the blood services. The blood services are already existing. We have to strengthen them. We have to make it more modernized. Ensure adequate supply of safe blood by expanding voluntary blood donation. This is one of the most important part which we are focusing on. Ensure safety and efficacy of blood and blood products. So for us, the blood products are equally important, and for ensuring these supplies, we have developed some good centers as well. Developing facilities for products of components and plasma derivatives. So this is very important because now we have this hemophilia program also with us, where we are also using these plasma derivatives for the clinical use. Strengthening quality management program, which is very important because every time the quality has to improve. Develop the strength and strengthen management and monitoring system. This is again a very important task for us, because monitoring for the country like India is very important, where it is so wide. In some of the states, you can see we have around 70 to 75 districts, and in another state it's like 10 to 15. But the states which are very wider, we need to monitor them regularly. Capacity building, training of all categories of staff, that is from the blood bank officer to the ground workers who are working with us day and night. And the use of effective intervention, as I say, that without implementation strategies like serum without a syringe. So these program strategies are not only strategies. When Mr. Chopra was talking about the cure and challenges. So these are some of the challenges which I'm going to brief you in my next slide. Next, please. Next, please. So we understand that safe supply depends on several important principles and key elements of proper infrastructure. We have seen that every blood bank should be in a proper shape. It is very important that the proper infrastructure is there. Adequate manpower and equipments are there, which is very important to run the services in any of the services. And to maintain the health systems, it's important that adequate manpower and equipments are there. Collection of blood only from voluntary, non-remunerated, low-risk donors, which is very important. Why I'm saying low-risk donors? Because we want to have the regular repeat donors. Our concern is to have the regular repeat donors registry, which will help these patients who have to go for the multi-transfusion. So this regular repeat donors, universal screening. When we talk about universal screening, that means across the country, there should be one screening system. Like if we are going for at least rapid test, or we are going for ELISA testing, it should be one. Tracking of TTI patients is again a very important task for us, because we come across so many patients, those who are affected with TTI. And important is that they don't come back to us with those infections. So those tracking is very important, and we are doing that tracking of HIV, hepatitis B, C, malaria even. Monitoring of the program, as I said, we have one monitoring system that is called r6l3jQcT9XM. We have also initiated with hemovigilance program and implemented of standardized quality management system covering all areas of the blood services. So that is again a big challenge for us. Administration of blood transfusion. When we talk about the administration, so the clinicians' roles come here, that they have to understand how we have to monitor these services while doing the blood transfusion. Hello.
มองพม่าไม่รู้มองละเอียดขนาดนั้นหรือเปล่า
So next slide, please, Devat. So here in India, health being a state subject, the owners of the blood services lies with the state health departments. Now, blood services has become a very important component of health systems. In India, we adopted this strategy in 2015. And now you can see the WHO global strategy also talks about the same line, that blood should be a part of the health system. It should be a part of health system strengthening, rather being the separate thing. It should be a part of a health system. The Director of Health Services, which is the head of the department in each and every state, we have requested them to do the mapping of the blood banks, blood storage centers, and blood transfusion centers, because the blood banks and blood transfusion centers work in isolation. They are totally different. So they have to articulate, design linkages between these centers, So for ensuring that the owners of procuring screen blood depends on the smooth reference between the site and not on the patient. This is very important for us. I understand Dr. Chopra was saying, Mr. Chopra was that the patient has to suffer. We are just trying a level best that the patient do not have to suffer, and these sites which are together there, that they are able to take care of our patients. India has 739 districts. I hope, many of the speakers must not be knowing that it is such a wide country that 739 districts are there, and 5650 sub-district talukas are there, where we are trying to have blood bank in each and every district and a blood storage centers in each sub-district. So blood components, you can see that they are being established with the aim that the maximum use of blood component is there. So wherever the red cells are being utilized, it should be only red cells. We are not focusing on the whole blood. Even in the peripheries, where we have blood storage centers, we are trying to accommodate with the blood storage centers where we have red cells, and the patients with PPH or with thalassemia or with other problems can get the red cell easily, or if they require platelets in the season of dengue, they can get. Even for the chemo patients also, we require platelets. So these can be kept at the storage centers. So when we talk about these, and this has to be taken care of because we need to do regular need assessments. Need assessments are important because you see in much of like Delhi, state like Delhi, we have a requirement of 3.5%. But in other districts, so regular assessment, need assessment of these blood units are very important. And accordingly, the voluntary blood donation camps are being organized as per the requirement of particular district to achieve the 100% voluntary blood donation with no wastage, which is the basically aim and ambition of this program. Dedicated staff for voluntary donation, because we are not taking care of the blood, staff from the blood banks. We wanted a separate staff who only do the voluntary blood donation, collect blood, give it to the blood banks, and the processed blood is being supplied to the blood storage centers. So licensed blood banks in India are providing standardized service delivery with well-trained staff and technicians.
Madam,
next, please. Yes. So with only 2 slides are left.
Thank you.
Next, please. Next, please. Actually, it's getting details because I am not able to operate. So clinical use of blood, which my previous speaker also said, it is very important and it has been promoted among the clinicians. Special transfusion requirements for hemophilia, thalassemia, and other marrow failure syndrome is being provided at the peripheral level through blood storage centers, particularly in the endemic areas. Blood banks are converted into center of excellence. Now the challenge is that we have to change our strategies. We have to come up with the blood banks which are called to be center of excellence, having automations. When we were talking, she was saying about the blood grouping. So we are also emphasizing on the automation of blood grouping, molecular testing. Then we have also having the blast freezers, which are very important for holding the plasma. So these things have been started accommodating in our blood banks. If you see, some of the states has really come up with those things. So these new technologies are being initiated in these centers, which are good centers and are able to train other centers as well. Random sample collection, this is another an initiative which we have taken. We just want to take one sample and check it at NIB or at AIMS, so whether these things are being done in a proper manner. And the last slide, the next slide, please. As I already said, that the monitoring is being done through e-Raktakosh and Hemovigilance. And e-Raktakosh is a comprehensive IT solution to connect, digitize, and streamline the workflow of the blood bank, which is very important for us. Safe and adequate blood supplies can be traced there, reduce the turnaround time, networking of blood banks, adherence to the Drug and Cosmetic Act, real-time blood stock availability, state, district-wide donor-based reports to blood banks, official and institutional. Recently, we started with the thalassemia online request on e-Raktakosh also. The thalassemia, on today's days, I can say that there are around 877 applications of thalassemia which has been online. And licensing committees are there, which gives license to the blood bank. So they are also the controlling authority and to monitor. Hemovigilance program is very successfully running in the states. And you can see some of the publications, you can see always that there are certain guidelines which has come up for the strengthening of blood services. Next slide, please. Strategies for augmenting blood donation, IPHS norms for blood services. This is a new initiative. We have Indian Public Health Standards, where the blood services has become a very important and core activity. And disaster management guidelines. During this COVID-19, we have to come up with the disaster management guidelines, which was very important to us. So these things have helped out, but yes, we have to really work hard to go ahead. And thank you so much.
Thank you very much, madam.
Good evening to all the panelists and a very warm welcome to all the participants from the 27 countries. I'm hoping that it's smoother as we go on. Like Dr. Nrula said, we are already 25 minutes past our time, and really it will cut down into the time that the patients have for their questions. So moving on straight away, the next section is focused on two areas that excite all our patients, families, and the clinicians as well. Reblozyl and gene therapy. May I take a couple of questions till we have the slides then, which are not pertaining to the presentations, but very topical now. So we've had questions from the patients, multiple questions. How are the thalassemics who get COVID-19 infection? How are they behaving? Professor Piga, could you answer this?
Oh, unmute.
Unmute yourself, yes.
Yeah, may you repeat the question?
So thalassemic patients who have been infected with COVID-19, how are they behaving in terms of morbidity? And are patients post-splenectomy, are they at increased risk? Do we have any information from the last 3 months or so?
Okay, we have up to now information on about 50 patients in the world infected with thalassemia, infected with this virus. There are 2 papers published, one from our group in Italy and another from Iran. And in our patient in Italy, the results are very good in the sense that no patient died, no patient had a very severe disease. Even a splenectomized patient didn't suffer so much. Some of our patients had complications like diabetes and other, but the course of the disease has been as in normal people or even better. These are the first set of results. A few days ago from Iran, a paper has been published with different results in the sense that there has been a more severe disease, some mortality, mainly in thalassemia intermedia, even if apparently well-treated patients. But all the patients that died or had a severe disease did have severe complication like heart disease, pulmonary hypertension, diabetes. So it's difficult to put together everything of these, but my opinion is that if a thalassemic patient, transfused or intermediate, has not a bad condition, that is treated at a sufficient level, he doesn't risk more than a normal individual from COVID-19, even if the spleen is out. This is what we know today.
Thank you. That's very encouraging. A couple of questions on blood safety to Dr. Vinita. Dr. Vinita, multiple participants have asked, we normally recommend blood up to 2 weeks old to be transfused to these patients. Because of the COVID-19 and donor crisis, this may not always be feasible. So up till how many weeks old blood should we say is okay to be given? Ms. Vinita or Professor Constantina, if you can take this question.
Yes, I can do that actually. We have actually almost similar problems, and we have some shortages of blood right now, despite the fact that due to a very successful task force exercise, we managed to achieve almost sustainability of blood, the blood supply. However, the group of about 4,000 thalassaemic patients and sickle cell disease patients have been recently complaining that they are not able in the Children's Hospital Hagia Sophia to get 2 units of blood transfused every 2 weeks, which is the norm for our thalassaemic patients. So we are trying hard really to improve the situation and see if we can manage. And I think that we will manage to do it, to improve situation. And so we shall come back to the moderate transfusion therapy, keeping the pre-transfusion level of hemoglobin at 9 grams per DL. Now, I would like actually to give an information, to take the opportunity to give an information following to what Professor Piga said about the Italian thalassaemic patients. In Greece, we are very happy that we have zero patient actually. No one has been infected by COVID-19, and but we have been taking measures in order to have this good result, and due to the very strict governmental measures as regards social distancing, personal protection of health and hygiene conditions and so on, we achieved that.
Professor Constantina, I'll move, because of the lack of time, I'll move on to another question. This is to specifically Ms. Vinita, that because we have a number of support groups participating in this session, they are finding it hard to convince voluntary donors to come to blood banks to give blood. Are there any initiatives that had been taken by the government to encourage donors to come, or some ways that we can make it safer for them to actually travel to the hospital?
See, there is an r6l3jQcT9XM where the donors can do the registration and the passes are generated and they can come to the blood bank to donate. Even the blood mobiles, which are the smaller blood mobiles, are moving across the donor doorstep. So that can be always taken care of. That can always be taken care of. It's only that the information has to be put in r6l3jQcT9XM so that we take care of these patients and the donors as well. That is the concern.
He's Professor of Pediatrics, Division of Pediatric Hematology and Oncology Department, Thalassaemia Center, Siriraj Hospital, Mahidol University, Bangkok, Thailand. And he's worked extensively in the field of thalassemia over the last 2 decades. He is going to start a very interesting session, which really excites all of us very much, about Reblozyl. So Dr. Whip is going to talk about the role of Reblozyl in HBE, thalassemia, and non-transfusion dependent thalassemia patients. Can we have your slides?
I'm going to talk about the Reblozyl in hemoglobin E beta thalassemia and NTDT. So as you know that in thalassemia, the globin imbalance is the major pathophysiology, and that leading to erythropathology, because unbound precipitated free alpha globin in beta thalassemia disease will lead to ineffective erythropoiesis, and surviving of this early erythroid cell into the mature thalassaemic red blood cell, it will further destroy in peripheral blood because of the precipitation of the alpha hemichrome. So for many years that we learned about this physiology of thalassemia, but we have no any medication that can directly tackle this ineffective erythropoiesis. And this ineffective erythropoiesis leading to hepatosplenomegaly and also extramedullary hematopoiesis in several tissue and organs. And of course, in the bone marrow will be full of these young progenitor of the So the luspatercept is the first in class of the erythroid maturation agent that have been developed to be used to tackle the problem related to the ineffective erythropoiesis. So this molecule will grab normally the TGF beta superfamily will bind and leading to the effect on inhibiting the erythroid maturation. But using these chimeric antibodies, we can grab these activin ligands and leading to driving of these terminal erythroid differentiation pausing and leading to a production more of the red blood cell. So I'm not going to discuss more because Professor Pika, my good friend, he's going to talk more a little bit after my talk, okay? So the first of the study, the major breakthrough just published in March this year from the study in the BELIEVE trial, which is the phase 3 randomized double-blind study of luspatercept in a patient with adult beta thalassemia patient who require regular blood transfusion or transfusion-dependent thalassemia. And Professor Capellini is the leading author of this publication. So in this study, and this is the key finding, which is you will hear more from Professor Pika, that show that in this primary result, if we can reach the primary key key endpoint and the secondary key endpoint. So the primary key endpoint is the achieving over 33% reduction in the red cell transfusion burden from the baseline, as you can see at the week 13 to week 24. So the overall population received around 21.4% in those who received the ribocil and only 4.5% in the placebo group, okay? And also in the first key secondary endpoint at the week 37 to week 48, you can see also significant difference between those who received the investigational drug, which is the luspatercept or ribocil, compared to the placebo. And also the study achieved over 50% reduction of the red blood cell burden from the baseline as well, comparing between the study group and the placebo group at the week 13 to 24, week 37 to 48, and of course at any 12-week interval and any 24-week interval. And this is the data that just published in March this year in New England Journal of Medicine. Further analysis, because the topic of my talk is on hemoglobin E beta thalassemia, which is a very common beta thalassemia syndrome in South Asia and also in Southeast Asia. So in the BELIEVE trial, we did some analysis, which is going to presented in EHA this year. So this is a sneak peek of the EHA meeting, which is a virtual meeting, literally. Comparing, we did a further analysis to compare between the response in the different beta globin genotypes, between the beta 0, beta 0, beta 0, beta plus, beta plus, beta plus, and of course, hemoglobin E beta thalassemia. So in this beta globin analysis, you can see that in different beta globin genotype from the overall group, you saw the data already from the primary publication. And when we do this sub-analysis, you can see that beta 0, beta 0, beta 0, beta plus, or even E-tau, it did not, only the E-tau did not really show that it has significant difference at the primary endpoint at 13 to 24 weeks. However, when we looking at the different time point at any 12 week, you can see that in E-tau also achieve the clinical response by the use of the ribocil can reduce the transfusion requirement over 33%, similar to the other beta globin genotype. And also in the further analysis of any 12 week, a significant number of patients with E-tau can also reduce the transfusion requirement over 50% in the study. And finally, at the 24 week, you can see that in E-tau patient also significant, and it seems to be even higher at the any 24 week after ribocil, that we can reduce up to 1/4 of the patient that they can reduce transfusion requirement by 50%. And based on my experience, because most of the E-tau patients in this study came from my center, and I can say, in my patient with E-tau, we usually see the clinical response so well after 3 months, beyond 12 weeks. And after that, the clinical response seemed to be very sustainable. In those who had this very good response, I can say, they are very, very magnificent. They used to receive at least like 4 units of blood transfusion, and now I can reduce to 1 or 2 units every 3 weeks and can still maintain the pre-transfusion hemoglobin over 11 grams per deciliter. The second part of my talk will be about the NTDT. So the data of the phase 2 study as already published by my friend, Professor Pika, whom you can ask him later on. And in the phase 2 study that also used in patients with non-transfusion dependent thalassemia show a very good response with the median time to response is only 8 days and seem to have a durable response in the patient with NTDT. More strikingly, this is the result from Professor Pika to show that, one of the most important complications in NTDT, which is delayed ulcer related to the chronic hypoxia in the patient, can resolve after the use of the luspatercept. So the data from the NTDT trial is not ready yet. So this is just only a sneak peek of data from my Thai patient. I just selected 3 patients with ETAL because actually in our trial, in our center, we have used luspatercept in NTDT over 40 cases, okay? But I just give you some example. Even in this study, we do the randomized double-blind control trial with the placebo, okay? However, as you can see on the screen, that, I can tell who actually got the luspatercept because in the baseline, the level of their hemoglobin is not, really changing. But after we start to get the luspatercept, you can see that even 1 or 2 injections, the level of the baseline hemoglobin has risen very significantly. One patient with a 43 years old increased from 7.3 to 9.5. Another 34 male increased from 9 to 11.4. And another male from 62 years old increased from 6.5 to 9.5. And this is all the NTDT. They never require any blood transfusion during the course of the study. So in summary, there's a clinical meaningful reduction per fixed and rolling period-based analysis in the red cell transfusion burden was observed across all the beta globin genotypes, although the response rate was higher in patients with non-beta zero genotype, especially ETAL. So the luspatercept or the ribosil was well tolerated across the beta globin genotype, including ETAL, of course. So the BEYOND study, which is this ongoing clinical trial in the NTDT, is supposed to get the data ready for presentation maybe early next year. And we also are planning to do the phase 2A study in pediatric population as well. Thank you very much for your time, and I think I can answer the question during the Q&A. Thank you.
Professor Pika is going to cover Reblozyl in transfusion-dependent patients. Professor Pika is Aggregate Professor of Pediatrics at University of Torino, where he teaches pediatrics and evidence-based medicine. After graduation in medicine, he's been working in pediatrics and hematology for many decades now. He's chief in charge of Division of Pediatrics and Thalassaemia Center of St. Luigi University Hospital, or Bazzano, where he designed and leads the transfusion and chelation programs and the prevention and prenatal diagnosis program. Professor Pika, we look forward to your presentation.
Thank you. May you hear me?
Yes, yes, very well.
And you see the slides. And you see the slides. So my topic is very easy, and because Professor Viprakasit said very well the introduction about this drug. And this drug now is approved since a few months in US, and the name, the commercial name is Reblozyl, and is given by injection, subcutaneous injection as insulin once every 3 weeks, and is going to be approved by the European Medicine Agency, the EMA, because the committee reviewed all the data and gave a positive opinion. So I guess in a few days, we will have an European approval for this drug too, and I hope for other countries. If you want to browse the evidence, the science on this, you may find two papers with clinical trials. One paper published last year, and both on transfusion-dependent patient and non-transfusion-dependent patient, and one trial this year on a larger trial, phase 3, randomized controlled trial on transfusion-dependent patient only. So what in transfusion-dependent patient is, this is the point, that is most of the patient at a variable degree show a clear reduction of the red blood cell transfusion burden, here expressed as percentage. So you see that some patient may, as this one, may not respond, so no change in the transfusion burden to maintain the same hemoglobin level, obviously, to keep on with the own transfusional scheme. And these patients do have a 100% reduction that is transfusion-free using this drug. So the response is very variable, individually variable. So on the average, the response is around this, let's say a reduction of 30, 40%, 50%. Is this reduction relevant or not for thalassemia, for transfusion-dependent patients with thalassemia? Well, I show you one of my patients on a luspatercept trial, and you see he had a 32% reduction of transfusion burden. You see the transfusion before the luspatercept. You see the rhythm in time and the number of units. You see 2 units regularly. And then here you see what happened using with this every 3-week injection of the drug. You see the hemoglobin tend to rise even without transfusion. And we had to reduce the number of units given. You see several times we gave only 1 unit, and or to wait for the next transfusion for the hemoglobin being relatively high. That is what on the average is happening. And what is the cost to pay for this? What are the adverse effects? Adverse effect like some sort of pain during the first time of starting the drug is very common, but generally speaking is mild. What is happening, what is more important and happening in a few patients, so in a small percentage of patients, if a thalassemia patient do have a trend to blood clots due to the splenectomy, due to the high level of platelets, due to many other factors that may be present in thalassemia, using luspatercept, there may be a worsening of this condition. So a patient may start luspatercept, but the doctor should have a close monitoring. And the same for blood pressure. Blood pressure normally in thalassemia is normal or low, and but some patients may have a high blood pressure. So in this case, the luspatercept may give a trend to hypertension. And then obviously if there is splenectomy or if a patient is taken hormone replacement therapy, there may be the same trend to we say thrombophilia, that is to form more blood clots than needed. And obviously other factors like smoke may negatively influence this therapy. That's all. That is that if this is the result in terms of efficacy And this is what I summarized too shortly, but the safety profile, this drug may have a place in the treatment of thalassemia. It's not a cure, it's not curing a patient, but may be very, very useful. We are continuing studies. Obviously, there are many other studies that we are running on long term. We do have today patients that are taking this drug since 6 years now. So we are very happy with the long-term result. And this is the my final slide that summarizes my opinion that for the new therapies, looking at the severity of thalassemia, you know better than me that there is a continuum of the severity of thalassemia major, transfusion dependent, intermediate, etc. To me, in the future, it is very likely that this drug will keep at most patient with a moderate and or severe thalassemia form, whereas the gene therapy should not fully overlap on these. There will be, to me, and we will discuss, I hope, also today, a lot of overlapping of these two approaches, but maybe that the part of patient may have better results with gene therapy and other with luspatercept. And maybe that stem cell transplant will leave for the most severe case of thalassemia major, where if gene therapy and luspatercept are not fully able to take the point. Obviously, having the conventional treatment that we know ready and high quality, possibly conventional treatment ready to rescue any patient where the new approaches are not able to take the point. Thank you.
Thank you, Professor Piga, for a very exciting presentation and your vision for the future for thalassemia patients. We've got lots of questions, but we'll leave them right till the end. Professor, can we have Professor Porter now?
Yes, yes, we can have Professor Porter's slides now.
The next two presentations will be on the status of gene therapy. Professor Porter will be speaking on the current status of gene therapy. Professor Porter?
Can you hear me?
Yes, yes. Yeah.
Excellent. Okay, I'm going to talk about gene therapy, and obviously we've just been hearing about non-curative therapy, but there are advances in curative therapy, and I'm going to try and put the advances in gene therapy in some kind of context. And the greater context is that thalassemia management involves not only curative therapy, but prevention and treatment, non-curative therapy. So about 280,000, 300,000 patients with beta thalassemia in the world today, with a birth rate of 50 to 60,000 per year. So we need to have 50 to 60, 100,000 per year. We need to have a preventative arm to overall strategy. Transfusion and chelation has been a major advance in the last 30 years, and we've been talking to some extent about that already. Allogeneic bone marrow transplantation has been rapidly advancing, and I'll show a couple of slides on that to try and see how gene therapy fits into the overall picture. With all these, we have to think about relative cost and efficacy in different parts of the world, because that balance of curative versus non-curative therapy will vary from country to country. Now, it's been estimated that with transfusion and chelation, only about 12% of children with transfusion-dependent thalassemia actually get adequate transfusion therapy worldwide. And about only 40% of those who receive transfusion actually get adequate chelation. So you can argue with these figures, but the point is that a lot of people with transfusion-dependent thalassemias don't get optimal therapy. And so The other issue is that if you carry on with non-curative therapy for a lifetime, you incur very large costs. So in the UK, a thalassemia patient of 50 years of age has cost about £500,000. And again, we have to think about new treatments in that context. With respect to non-curative therapy, transfusion and chelation, we also have to provide infrastructure. So as most of you know, and most patients know, that just giving transfusion isn't the whole story. And you need a support team, you need infrastructure, you need monitoring. And that's why it's so challenging for patients. And that's why many patients do actually want some sort of curative approach. Now, the curative approach that's best tried is allogeneic bone marrow transplantation, which has been available since the mid-80s, pioneering work from Lucarelli's group in Pesaro. And as of 2014, a big review, over to 3,000 transplants cumulatively worldwide. And the outcomes with these are very dependent on the age at which they're done. So if you're doing sibling transplantation, which is the best outcome group, if you do the transplant below the age of 5, the mortality will be less or equal to around 5%. Then up to the age of 14, you get a mortality, procedure-related mortality of about 10%. But then when you get into adult life, that goes up to perhaps to 20%. These are shifting numbers, but this is what's quoted in the literature. And the effects, or the unwanted effects of bone marrow transplantation are acute or chronic graft versus host disease. I won't go through the numbers now for reasons of time, but these can be limited by a multitude of approaches, such as anti-thrombocyte globulin, better risk stratification, dose adjustment with busulfan, and so on. I say this just to put the gene therapy into some sort of context. Now, the next slide I have here is the results of the EBMT registry, which really complements what I've already said. So with HLA sibling donor, you get a overall survival of about 93%. If you have other donors, such as unrelated donors, that falls to about 87%, and haploidentical donation falls still further. These are, again, a rapidly evolving numbers, and we expect these to improve, but nevertheless, that gives you some flavor. So with gene therapy, is the gene therapy slide showing for you now? It's a big slide saying gene therapy. Is that what you have in front of you at the moment?
That's right. Yeah.
Yeah? Okay.
Yeah,
so there are various approaches to gene modification used in clinical trials. In principle, you can correct the abnormality of the missing gene by gene addition, and that's really the approach that's adopted with lentiviral vectors, or you can aim to correct a single point mutation with designer nucleases, CRISPR, for example. And one approach there is to manipulate fetal hemoglobin to a level where the patient can support a hemoglobin from fetal hemoglobin alone. Because with thalassemias, there's over 200 different mutations, the latter approach it needs to be done with manipulating fetal hemoglobin or by gene addition, as I mentioned at the start. So the approach which has been adopted with gene addition, the most advanced is with lentiviral vectors. And this was first done in a thalassemia intermedia mouse model over 15, 20 years ago. And this was subsequently then shown in a thalassemia intermedia patient to be effective. But obviously what we're aiming for in the longer term is for it to be effective in thalassemia major patients. And for this to work, the vectors have There's 3 groups at least in the world working on this, and they share a number of approaches. Promoters are required. The insertion locus is critical to both efficacy and safety. And then there's been a lot of argument about the use of insulators. Now I'm going to talk in most detail about the Bluebird Bio product Zynteglo as it's been rebranded, because this is the most advanced in terms of clinical trials. And these trials began with phase 1 and phase 2, studies 204 and 205, and then went on to phase 3 with an improved manufacturing process, which has a number of advantages over the original trials, which I'll show you. What all approaches at the moment share is that in order to get the gene product into the patient, you have to do a number of steps. First of all, you have to collect the patient's own stem cells with some kind of mobilizing procedure, typically with GCSF and Plurixifor. They collect the stem cells on a cell separator. You then have to purify those and send them to a lab for the gene correction procedure. Typically, once that is done, the corrected cells can be kept frozen for months or even a couple of years. When the time is right, the patient receives myeloablative chemotherapy, typically at the moment with busulfan, although other conditioning regimes may develop and with which possibly will have a better tolerability. And then following the infusion of the busulfan, the actual infusion of the corrected gene happens a day or so later, and then one waits for the regeneration of the bone marrow for a period of weeks. Lentiglobin gene therapy in patients with beta thalassemia is, as I say, the most advanced, and the phase 1-2 studies, HGB 204 and 205, was published in New England Journal of Medicine last year. And adopt what I've just said there. I won't go through that again. And this was reported 12 out of 13 patients with non-beta 0, beta 0 thalassemia became transfusion independent and maintained a useful hemoglobin without the need for transfusions. And a few patients with beta 0 genotype were included. And overall, the transfusion requirement using this initial manufacturing process was decreased by 73%. The tolerability reported in this paper, there were the treatment-related adverse events I will show you now. So this is the hemoglobin achieved with time. So on the horizontal axis, you see time after the transplant. The red is the study 205 and the blue is the study 204. And then the lighter bars are the time to development of transfusion independence. So typically, the time to transfusion independence would be about 3 months with regeneration of the bone marrow following myeloablation. Some patients take longer, and the average hemoglobin that was achieved in this study was typically in the region of 90 to 100 grams per liter. Some patients had lower values, as you can see, 82 or 83, but good hemoglobin values were achieved, and these seem to be sustained. Then an improved manufacturing process was developed, whereby the so-called vector copy number, the number of copies of the corrected gene per cell on average, was improved. So you can see on the left in the original phase 1-2 studies, the average vector copy number was around 1 or less than 1, whereas with the improved manufacturing process, this went up to about 3, and the proportion of cells which were transduced also went up to about 80%. And then you can see the effect on hemoglobin in this study. So this is in the phase 3 study, study 207. And in red, you can see the production of the corrected gene. It's got a marker on it called T87Q. So you can see that most of the hemoglobin, it results from the corrected gene, whereas a little bit extra which results from the patient's own red cell production. And this is because these are non-beta 0 patients. So they've got a residual amount of their own hemoglobin production, and that contributes to the overall hemoglobin. In terms of tolerability, most of the effects, someone's talking there, it's very much what you would expect from myeloablative conditioning, thrombocytopenia, anemia, leukopenia. I think an important effect that can be seen with busulfan in high doses, veno-occlusive disease, and we saw a case of this, which can be difficult to manage. But since prophylaxis has been adopted, the occurrence of this has gone down very considerably. Now studies are ongoing for beta 0 mutations, the so-called study 212. These have not been fully published yet, but they have been presented at meetings. And patients are achieving transfusion independence generally with the same tolerability profile to the beta plus patients. So this is an exciting development. So it looks to me and to others that in transfusion dependent beta 0, this approach will result in transfusion independence. For balance, I should include the approaches using hemoglobin F synthesis and modulation, and this is being developed by a number of companies. One is by Novartis and the other is by CRISPR Therapeutics. These trials are ongoing, and clinically relevant increases in gamma globin have been reported initially in a mouse model and more recently in a single patient. So CRISPR Therapeutics with Vertex presented a patient back in November who had beta thalassaemia, and this patient was a beta 0 beta plus patient who was requiring about 16 transfusions a year. 9 months after treatment, this patient was transfusion independent. This is the only case that's been presented so far, but clearly shows proof of concept, and we need that data to mature a little. But it looks as if this CRISPR approach with modulation of fetal hemoglobin and other aspects of conditioning, very similar to the lentiglobin approach, will be a good one and will be effective. So for reasons of time, I'll stop there. Gene therapy has now been shown to provide transfusion independence with overall good toxicity profile, both using, certainly using the lentiglobin vector, and a parallel approach using CRISPR and manipulation of fetal hemoglobin is in early clinical trials, but proof of concept has been shown. The authorization and reimbursement process is now ongoing country by country, which is proving to be quite complex, but hopefully that will be sorted. Thank you very much.
Thank you, Professor Porter. Again, an exciting presentation, and I know most of the participants are from the CRO region where access will continue to be a challenge, but nevertheless, both Reblozyl and the recent successes in gene therapy are exciting for us, and we are all fully aware that the gap between availability and accessibility is shrinking, as we move on. So to continue on the theme of gene therapy, we next have Professor Regine Grosse, and she is going to talk about setting up for gene therapy. She's a specialist in pediatric and adolescent medicine, pediatric hematologist, pediatric hematology and oncology department, Thalassaemia Clinic, University Hospital, Hamburg in Germany. Professor Grosse, can we have you now?
Can you hear me?
Yes, we can hear you.
Okay, can you see my slides too?
Yes, yes, very well.
Okay. Yes. Hello to everybody. Hello to John and Antonio. Nice to see you in these hard days. Actually, I think one of the biggest questions is probably the costs of gene therapy. And Germany will be the first country in the world where gene therapy will be done by health insurance and will be paid by health insurance. It is really quite expensive. It's about 1.6 million euros. So I think it's a I will not know how much it will be in US dollars or pounds. So because it is that expensive, there is a deal with the health insurances that the cost will be paid in 5 different sections. And that means the first section, when you make the gene therapy and when you make the conditioning treatment and the apheresis, that has always to be paid. And then for the next 4 positions, they will only have to be paid year by year if the gene therapy was positive and the patient will stay transfusion free. Otherwise, the health insurance will not have to pay the costs. So you see there will be 13 qualified centers in Europe. So there will be 3 centers in Germany. There's only 1 center qualified yet, that is in Heidelberg, and Essen and Hamburg. We are still in the contracts setting with the lawyers. So hopefully we were planning this summer, but then the coronavirus infection threw us down. So hopefully by this September, we can start with gene therapy because the patients are already waiting. So one of the questions I was asked from TIFF was, how were the selection criteria? And actually, this is probably a question you have to ask Bluebird Bio. But so they said that they wanted to see the expertise in the indication of gene therapy in thalassemia and also the integration. They wanted to have a quality-proofed stem cell transplantations, and they wanted to see that there's capacity to do gene therapy in these patients. And then there was a hard process with the IT, the protection of data privacy and logistics, and we are still not finished with this. And as you can imagine, as gene therapy is pretty new, it's very difficult also for the lawyers. So then there have to be contractual agreements with Bluebird Bio about the responsibility and the quality and tracking of the patients, as the patients have to be followed up now in Germany for 30 years. So it was planned to have a follow-up for 15 years, but now the follow-up will be for 30 years, and the patients have to sign this contract. Yeah, and then we have different courses about the instruction, about the run of the process, about the apheresis and the administration of the new product. So with the next slide, you see that all 3 centers were working together and that we were building a checklist. And we were discussing this checklist with the health insurances, so to make it easier, because it's not that easy that you say, okay, you want to have the gene therapy in this special patients. No, you have to make this checklist, and then you have to write to the health insurance, and then they will decide if this patient is eligible for this. So first you have to check for the age, and the age should be between 12 and 55 years. Then you have to show the gene type of the thalassemia, and it must be a non-beta zero thalassemia. So it can be beta plus, HBE beta zero, HBE beta plus, or beta plus beta zero. So then they want to know the history of transfusions, and they want to know the milliliter of blood transfusion by kilo for the last 2 years. Then, of course, you want to know if the patient is eligible for high-dose chemotherapy if the patient has no severe organ damages and that you hopefully have no complications. And also we have to show that there is no HLI matched family spender, because if there will be a HLI 10x10 family spender, then gene therapy will be forbidden and it has to be done a stem cell transplantation. So of course you have to measure the liver iron concentration. It's yet not forbidden to do gene therapy even in higher liver iron concentrations, but we decided that we would like to have a low liver iron concentration. As John said, you will have probably higher complications with the condition and treatment, and so that's why we want to have the patient well chelated, and of course you want to have the patient having no cardiac iron overload. The patient must have no hepatitis C or hepatitis B or HIV. Of course, if the patient had a hepatitis C, for example, and you cured the hepatitis C by antiviral treatment, then the patient will be eligible for gene therapy. They want to know if the patient is having hypersplenism, and if yes, they want that there is a discussion about splenectomy. And of course, the patient has to sign the contract for the therapy and also the contract for 30 years follow-up. So that will take time, and that's a timeline. And you see, being the clinician, you start with a checklist and see if the patient is at least eligible. And then you have to write to the health insurances for application, and that will take around about 4 weeks. We don't have that much experience yet, so that's what the health insurances told us, that it will take about 4 weeks. Of course, you want to have a fertility management in these patients, which you can probably already start during you have your health insurance application. You start a hypertransfusion regime, then you start the apheresis and the production of the modified stem cells, and that will take till we get the modified stem cells back from Bluebird Bio. It will take about 6 weeks. Then the conditioning will start. This is the high-dose chemotherapy at the moment with busulfan, and then it will take about 6 weeks with the reconstitution, and hopefully everything went fine and the patient will be discharged, and then at least there will be a follow-up for 30 years. The follow-up will be, of course, in shorter time periods in the first time, and then over time it will be just once a year. So that's how it should work. I can't tell you about own experience at the moment because we're still in the time, we are still waiting for all contracts be signed. And but I know that Heidelberg has done already 2 successfully gene therapies, and so hopefully at ASH I can tell you more. So
thank you.
That's it.
Yeah. Thank you, Professor Grosse. It is really exciting to see gene therapy move from the lab to the real clinical setting, and I'm sure exciting times will follow. Again, we have lots of questions. We'll take them at the end. I'd now like to invite Professor Tulika Seth, because we now move to the challenges of the CRO region. So she's going to talk on the Indian perspective on innovative drugs. Professor Tulika Seth is Professor of Hematology at All India Institute Medical Science and has a very program. She is member of the Clinical Epidemiology Unit and has many other laurels to her name. Professor Tulika, over to you. Professor Tulika?
Hello.
Hello, yeah. We can hear you.
Thank you.
Yes, we can.
I'd like to thank the organizers, especially TIFF, for inviting me and letting me participate in this wonderful panel discussion. A little bit on the Indian perspective on the innovative drugs. So as you know, India is a really big country. We have approximately 150,000 people living with thalassemia. And in this big country, we have a huge blood burden. And in that regard, the innovative drugs are very exciting to us. You've already heard some wonderful talks on luspatercept and how it reduces transfusion need in adults not eligible for curative therapies. Unfortunately, we have not got access to this drug, so we don't have any experience. I'll touch a little bit on the other innovative drugs, hepcidin, analogs, ruxolitinib, thalidomide, and hydroxyurea. So this drug has already been discussed, how it is effective in improving the quality of life in older patients and decreases the transfusion frequency or the transfusion amount, and that helps to control the iron load. And there's certain things that we have to take care of, especially in splenectomized patients, and give anticoagulation or antihypertension. But as I said, we have not used it. The other innovative targets are hepcidin and ferroportin, and there is a hepcidin mimetic, which is which has been studied as a proof of concept trial in hereditary hemochromatosis, and a phase 2 trial is ongoing. There are also some siRNA which are being tested, and there's a ferroportin phase 2 trial, and we've been approached, so hopefully India will also participate in the ferroportin trial, and these drugs help to maintain the iron balance. So although we already have 3 iron chelators, sometimes it's useful to have other options as well. So this is something we're looking forward to. Ruxolitinib is approved in India for primary myelofibrosis, but it's a very expensive drug. There are some excellent data showing a consistent reduction in the spleen volume in the TRUTH trial in patients who were given ruxolitinib for hypersplenism. In India, we usually find hypersplenism and splenomegaly in patients who have had inadequate transfusion support. So we try our best to improve their transfusion and give an increase in concomitant chelation. And in over half of the patients, we're able to prevent splenectomy. In some patients, because they have alloimmunization or very high serum ferritin, we often add hydroxyurea, and we're able to, in some of these patients, again, avoid splenectomy. Thalidomide has been studied more in non-transfusion dependent thalassemias, but along with hydroxyurea, there are some trials, and the largest trial that I found from India had 167 patients, of which 139 were thalassemia major, and a significant number of them did have response to this combination, though there was a 15% loss to follow-up. But there was a lot of toxicity in the form of neutropenia, hepatotoxicity, and stroke. There are other inducers of fetal hemoglobin, most of which we have not been using, again, because of toxicity or cost. But hydroxyurea is something that we have used. And there are a lot of benefits of hydroxyurea, apart from increasing the fetal hemoglobin, though more data is there in thalassemia intermedia and sickle cell, but there are some data from thalassemia major. The predictors of response are not very certain. There's a lot of studies and a lot of work has been done, but we're not exactly sure. It might be related to the XMNL polymorphism and maybe some mutations and alpha gene inheritance. There are some trials of hydroxyurea from India, and the largest trial that I found had 41 patients of thalassemia major. And in the thalassemia major patients, 32% of them showed a 50% reduction. But again, the toxicity was very high. 19% of patients could not tolerate the drug. So most of the data from our country are small studies. Wider use is not being done, even in the groups who had studied these drugs because of toxicity. And now as patients are getting older, it's more important for us to look for other options to decrease the transfusion burden. And especially during the COVID crisis, several of us have been thinking about using hydroxyurea alone or along with thalidomide. Luspatercept looks like a very good option, though we'll have to see the affordability of this drug when it comes to India. So thank you very much.
Thank you, Professor Tulika, for this overview of what is available with us and what will become available to us in the future. I now request Professor Alok Srivastava to talk on the Indian perspective on innovative curative treatments. Professor Srivastava is Professor of Medicine, Department of Hematology, Head Center for Stem Cell Research at Christian Medical College. Professor Srivastava, over to you.
Thank you, Dr. Amita. Can you hear me?
Yes, yes, very well.
And you can see my screen?
Yes.
Can you see the screen?
Yeah, we can see your screen.
Okay. So, good evening, good afternoon, everybody. Thank you for inviting me to this webinar. I want to thank Thalassaemia International Federation and Thalassaemics India, as well as TPAG, for including me in this program. What I was asked to do was to give you an Indian perspective on curative therapies in 5 to 6 minutes, and that's what I hope to do. You have heard from Dr. Porter that
can you make it
there
full?
are more than 50,000.
We can't see the bottom part of your slide. Can you put
see
it
now? It's full screen. It is slideshow now. Can you see it?
Little better. Please go on. Please go ahead. Let's not lose time.
Okay. So, Professor Tulika has explained the numbers that we see in India. All I wanted to say is, we have been doing transplants for thalassemia major from 1991 in India at our center, in the world, as you know, from 1981. But as has been pointed out, less than, well, 3,000 was the data from EBMT, but if you put all the other data together in the world, it will be somewhere between 5 and 10,000 that have been performed in the world. So the discrepancy between the numbers being added and the numbers that are being cured through transplant is just so huge that at a public health level, transplant really has had no impact whatsoever. We have done more than 600 transplants for thalassemia major at the Christian Medical College, Vellore in India. And it is certainly a huge celebration for the family that succeeds. But when we look at it from a public health point of view, this has really no meaning. So therefore, we've been looking at alternatives, and obviously gene therapy has been something that we've been very interested in. There are certainly more options for transplant now with unrelated donors and half donors being used. Those results, in our view at least, are not yet so mature to become a routine practice. Complications are more. So gene therapy, as you heard just now, is now a reality, and we just we just listened to Professor Porter, who explained how this is being done. What is being done is to take the stem cells, treat it with a lentiviral vector, do the transduction efficiently, and if all looks good, then do an autologous transplant, which normally should have next to no mortality. So compared to allogeneic gene therapy, where you give a stem cell with a normal gene, here you're taking autologous stem cells, correcting the gene, and then putting it back. Yeah, a very different game altogether in terms of complications. So this is the product. We should certainly celebrate it, except that we can only watch it from a distance when the cost is in the range that we just heard. So this cost is very artificial, and I'm not sure that we will get a chance to discuss that. But there's a whole philosophy of costing products, which is called value-based versus cost-plus. And this is all value-based costing, which will keep it out of bounds for a lot of people who are on the call, on the webinar today. So given that, we knew this will happen many years ago while this research was going on, and therefore wanted to have our own effort in doing this. What this slide shows summarizes, some of the general approach that has been explained. So you have a person with thalassemia, you take this person's stem cells, you then need to modify it. You can modify it in several ways. And what was described by Professor Porter was, gene addition, usually with a lentiviral vector. You can also use lentiviral vector to modify genes. And one of the gene modifications being done, we initiate the transcription or in a way that the hemoglobin F rises. And then of course, gene editing. Gene editing using CRISPR-Cas9, or much more recently using base editing. So all these approaches are actually being done at the Center for Stem Cell Research in Vellore. We are fairly advanced in all of these. We have reached the point where the design of these products have been completed. Their in vitro testing in the cellular models have been completed. We are now using human hematopoietic stem cells to test them in the NSG mice. So once that is done, the big challenge will be the vector production. So that is something that is a challenge for the entire developing world. There's hardly any capability to produce vector, and this needs to be addressed. I don't have time to get into that, but we are certainly trying to see how vector production can be initiated in India. I'm glad to say that the government of India, through the Department of Biotechnology and the Ministry of Science and Technology, has been extremely supportive, and all this work is supported through there. So I wanted to just show you a little bit about what referred to. So we have tested several vectors. This is the example of 2 vectors that we have tested in the sickle mouse model, and what this shows you in the hemoglobin electrophoresis done at the bottom of the slide, that there is significant production of transgene hemoglobin through these vectors. So we have selected one of these to test in the NSG mouse using human hematopoietic stem cell, and we will do secondary transplants with that, and if that looks good, then that's where it stops in terms of animal testing for these vectors. It will then be able to move to an IND. So this is, while we are doing this, we have interest in gene therapy in other hematological diseases as well. And one of the areas where we've been working is hemophilia. The only reason I mentioned this today is because here we are proposing a first-in-human lentiviral-based hematopoietic stem cell transduction of the factor VIII gene using a lentiviral vector. So this is a good platform for us to actually initiate this system in the country, because the processing for this will be very similar to what we hope to do for the major hemoglobin disorders. So this is fairly advanced, and this has actually been in an IND application. In India, it's already approved. In the US, it's going to be a combined study with slightly different conditioning protocols in two countries. If all goes well, this will probably be initiated before the end of the year. This vector has already been produced, and what we are testing is the clinical GMP vector. So I want to stop there with this final slide, just to say that there are several products that we are looking at for hemoglobin disorders, both lentiviral vector and gene editing approaches. We hope to complete the preclinical evaluation in the next 6 to 12 months. The major challenge will be a clinical grade vector production, but thankfully we have collaborations internationally that will give us the phase 1 vector, after which we hope to establish production in India. So the goal really is to make gene therapy accessible to those who cannot afford the zinteglotide of cost. And that really is where we're going. Thank you for your attention.
Thank you. Thank you, Professor Srivastava, for sharing the exciting work being done at your center, and for also for giving hope and optimism to the entire audience from Seattle region that we may have accessible products in not too far off future. Thank you so much. The last speaker for this evening is perhaps very important, because he brings the patient's voice to all the 3 topics that we've been discussing. This is Dr. Soumya Santra. He's a doctor. He's done his master's in pharmacology and is currently working in geriatric medicine. He's an active member of the Thalassaemia patient advocacy group, and he's been chosen to represent the patient voice on the 3 topics innovative curative treatments, innovative drugs, and blood safety. Dr. Soumya, glad to have you here. Please, over to you.
Very good evening. Yeah, am I audible and my slides are visible, right?
Yes. Very well. Very well.
Okay, so perfect. So a very good evening on behalf of Thalassaemics Patient Advocacy Group. I am Dr. Somu Satra. I have done my pharmacology as I already introduced. And today I am talking on behalf of TPAG, and I thank TIF and also Thalassaemics India along with TPAG to give me this for giving me this chance to talk. So as we have already talked about all the scientific fiesta, and I think there's a very bright dawn for us, but still we are in the dusk, and we are in the dusk because we are living in the dusk because of the geographical situation of the country, where you have geographical diversities, and other than that we have political diversities. Though the policies have been made from the government of India, but as patients from different regions of the country, we are still not getting the accessibilities and affordabilities to measure of the systems and the advanced protocols. But we will not talk about the advanced protocols. We will talk about the basic need that we have as per the thalassemics, that is safe blood. So when the government of India has planned for various new strategies like one India, one nation, one tax, one election, one ration card, but still why in case of healthcare, it is different for different parts of the country. And so with the aim of that, TPAG has taken steps for the initiation of the concept of safe blood. And since 1987 and 1988, when the safe blood concept was there in India, till then until now, we have not progressed a lot, we can say, in the, when it comes to the cities or in the secondary cities or in the villages of the country. And as Vinita ma'am have already told, that its policies are there, strategies are there, implementations is a problem because of the diversities and of the district. Many of the districts have not even don't have the accessibilities. So TPH's Safe Blood campaign, it has gone a long way, and we have many more missions and visions to run it along. So to say a short about TPAG, it is a patient-based forum or a platform, you can say. It is the adult thalassemics from various fields of psychology, law, IT, education, along with members from various other fields, have taken part in raising the voice and leveraging our voice to the right platforms of the country. And for the right platforms, we take the four stakeholders, that is the parliament, the government, the media, and the judiciary systems. So in 2017, along with the help of Manish Sisodia, we launched our TPAG role in India. And our simple mission we have is to protect the overall interest of the thalassemics and prevent thalassemia. And as you know that we are constantly trying to decrease the birth of thalassemics, so a load of adult thalassemics is much more. And for this adult thalassemics, yes, there is a cure in the recent future, but ultimately, as of now, we have no cure, but only care. And for care, our vision is to advocate a thalassemia-free India where all thalassemics are cured or healthy. So for us, adult thalassemics or thalassemics that are already born, it is the to remain healthy. And to remain healthy, we have strategies. We have leveraged the collective voice of our empowered groups of thalassemia patients all over the countries from various geographical locations, and engaging the four estates of the Indian democracy to achieve our mission and vision. So coming to the proper care of our thalassemics, the safe blood. Yes, our campaign objective is to promote and advocate adoption and implementation of safe blood. And as you know, that blood is a vital healthcare resource, and it is a resource not only for the thalassemics, but also millions of cancer patients, the dialysis patients that receive blood throughout the year. And you know that India is a land of HIV, HCV, and HPV infections. We have a wide majority of patients suffering from this, and most of them are asymptomatic. So they are the potential carriers, and we are at risk of this treatment transfuse-based infections. So what is safe blood for?
Dr. Soumya?
I think we lost his contact.
But I think he's very aptly put across the patient's perspective in all this. I think that brings us to conclude, to all the presentations that we have. Our time for questions has been limited to 20 minutes. So, and we've got lots of questions from patients, participants. So I'll request Dr. Khanna to take over the first few questions, and I'll follow up.
Hello, am I audible?
Yes, Dr. Khanna.
Yeah. Now we start our question answer session. Since we are running behind schedule, I'll request all our experts to give a very short answer to all the questions. We have a list of questions, though I don't have the name of the person who have asked these questions, because these questions were given to us in advance by our participants. So this first question is addressed to Dr. Vip. Is he there on the line? Is Dr. Vipraxit there?
Yes, I'm still here.
Yeah, thank you. The first question is addressed to you, sir. Is the effectiveness of luspatercept related to any of the mutations, particular mutations, or XMN polymorphism?
I don't think it's related directly to the XMN1 polymorphism, because the mechanism of the compound itself is nothing to do with the upregulating the gamma globin expression or the globin switching. Okay, so it just released the pausing of the terminal erythroid differentiation. The globin genotype seem to be very important, especially the type of the beta globin mutation. As I show you that the response in the beta 0 seem to be less compared to those who have the beta 0 beta plus or even hemoglobin E beta tau.
Okay, thank you. There's another question. I'll just ask that one also because somebody has asked about that. Does luspatercept affect the fetal hemoglobin levels?
Well, I think I can answer this. We have looked at this data. We saw some signal. I mean, this is just my personal opinion. That is probably not directly related to the direct mechanism of the compound, but maybe when we make ineffective erythropoiesis, we may drive some of the erythroid clones that has a higher propensity of the gamma globin expression. However, this is very premature to say that. We are still in the process to analyze the data.
Thank you very much. Can I have Dr. Piga, please?
Yes.
I have one or two questions for Dr. Piga. Yes, sir. Does luspatercept have does luspatercept have any effect on the immune system?
Oh, the simple answer is no. Even if we cannot be fully sure of this because there has not been a specific study on this, but from the data we have, the answer is no.
Okay, another question I think you can answer better than anybody. That is there any chance of drug tolerance? That is the effect fading with time with the use of luspatercept?
Sorry, may you tell again?
Drug tolerance. Is there any chance of drug tolerance? Body tolerates that with time the effect fades, decreases the effect with time?
No, we have, I may say, a strong evidence that there is no trend to lose the effect on time. And as I said, we have patients that are on 6 years now. It's a protein, the drug. So as for any protein, we are on long term following up if there is the case of formation of antibodies against luspatercept. And this is in the case in thalassemia for 0.4% of patients at very low level, so not clinical level. So in theory, a lot of antibodies against the drug losing the effect. From the practical point of view, we are not seeing that at all.
So clinically, there is no effect on the efficacy over the period of time. No, thank you, sir. Now, Dr. Tulika said, when is it likely to be available in India, luspatercept? Madam, Dr. Tulika said, when is luspatercept likely to be available in India? Hello?
Hello, can you hear me? Yes.
Yes, I can, madam. Yes, madam. When is this drug likely to be available in India, and what are the costs that we are expecting for this? Because I know that it's in US it is very expensive at present, somewhere around more than 3,000 pounds, $3,000 per 25 grams. But what is the expected date of arrival of this drug here? Because everybody is eagerly waiting, and can it be used in adolescents, younger children? It's been approved for adults only.
I don't know about the studies in children and adolescents. I don't think the approval for that age group is there. I think in the US, the approval is there for adults only. And of course, when it comes to India, it will have to be approved for adults because that is where the data is. The cost when the company comes to India, there are many companies which give differential pricing to products in India so that the price is affordable to Indian patients, but some companies do not follow that policy. That we'll see when they come.
Thank you, madam.
Can I answer the question regarding adolescent study? Our Professor Cooper and myself, we are steering a committee for another clinical trial of the luspatercept. So we in the process, but you know, we supposed to actually have already started, but because of the problem with the COVID-19, everything has been delayed, and I cannot enroll any patient because of the policy of the hospital. So that's
we've gone back by I think a decade or more. Yeah. And can I ask next question to Dr. Alok Srivastava? Dr. Alok Srivastava, please.
Yeah, I can hear you.
Yeah. As in the case of BMT, a younger age produces better outcomes. Does the same apply to gene therapy also?
So as you saw from the current trials, gene therapy is being offered only to adolescents and adults. And they are trying to do it in not too old people at the moment because they want to be sure that other factors don't affect the results. But ultimately, once it becomes more widely available, it will be the aim to offer it to children. This concept of gene therapy using lentiviral vectors is already in place for immune deficiency for many, many years. And young children have been treated with that and safely now. So ultimately, it will go to very young children, but it will start with older children, adolescents, and adults.
Now, I have one more question that is for Dr. Vip. Is the efficacy of luspatercept affected by the age group or serum ferritin levels? Somebody is asked. Dr. Vip? Can you hear me, Dr. Viprasit?
Forgot to unmute. Can you hear me?
Yeah.
Okay.
Could you hear the question?
Yes, I heard the question. Based on the analysis, there is no differences between the different age group of the patients. So the clinical response in the study population, which is over 18 to 65, I think, there is no difference. And also the level of the iron status, the patient doesn't seem to affect the clinical response. Well, however, the data in patients younger than 18 is not available, so we are doing the pediatric and adolescent trials, and we might be able to answer that.
Last question. Thank you, sir. Thank you, sir. Last question I have here is Mr. Bidan Sarkar from Bangladesh has written, the patients in Bangladesh are suffering a lot and lead a poor quality of life. TIFF has taken a great initiative to spread the advanced therapy all over the world. His question is, I think if Dr. Andrula can address. Is Dr. Andrula there?
Unfortunately, Dr. Andrula had to leave.
You can answer, sir. Dr. Mike.
Yeah.
He wants to know, yes, he wants to know how can he bridge the process of this, taking the advanced therapy to Bangladesh?
It's not just Bangladesh. The question of access, the question of affordability is universal. At this particular moment in time, even some European countries do not have easy access and easy affordability to any of these new therapies. So basically, we need to wait, we need to advocate. TIFF, along with its member associations in whatever country, should get together and find ways to advocate with governments. Advocate so that these new therapies can become available to people. At the moment, very few can benefit.
I hope Mr. Bidan Sarkar has heard this and he'll follow that. Dr. Amita Mahajan?
Yes, Dr. Khanna, thank you.
Can you carry on now with the questions? We have 10 more minutes.
Before I start on the questions, there are two overwhelming pleas from all the participants. First is again to reiterate to TIFF, because it's a very big appeal from all the participants that TIFF plays a major role in advocacy for patient access. So with these new coming, we will need their help with insurance, with compassionate access programs. So very big request to TIFF to play a very active role in that. The second big plea from almost all the participants is for the panelists to share their slides. So may I request the host to actually ask for a consent, and for those panelists who access it, the presentations can perhaps be put on the TIFF website so other participants can have an access to these. So after that, I have just a few quick questions. The first to Professor Piga. Professor Piga, you'd highlighted that thrombosis is one of the few side effects in a small proportion of patients who take Reblozyl. For patients who are at high risk, such as post-splenectomy, or who may have had a thrombotic event in the past, should they need to be on prophylaxis for thrombosis prior to starting this drug, or should we just monitor them closely?
Yes, you know that in thalassemia there are many factors that may push for thrombotic risk. And so the first is splenectomy, because we know that after splenectomy, there is the number of platelets that are circulating is high, and the level of activity of platelets is higher than normal, as well as the number of red blood cells with alteration is higher than normal, because there is no spleen to remove the most abnormal red blood cell. So this is well known. But also in patients with the spleen, they may have a trend to thrombosis sometimes, because there are genetic and acquired factors that, as in any individuals, that may do that, and so also in thalassemia. But is not, these conditions are not contraindication to use luspatercept. We are using luspatercept in many splenectomized thalassemic patients and many patients with risk factors. Obviously, we do prophylaxis if clinically indicated, as without luspatercept, and we go on with strict monitoring, and the results are pretty good.
Thank you. Another question to you, Professor Piga. We know that we should give the drug for 6 to 9 weeks. When would you, because different patients respond differently to Reblozyl, what would you consider failure of response to Reblozyl, and when should the drug be discontinued? So, what increment would you consider a satisfactory response? What, would you consider unsatisfactory, and for how long would you give the drug before saying that a patient has not responded adequately?
Very good questions. So how long? It's easy, because from our data, we guess that a 3-month period, that is a 3-month test, is enough to understand if an individual patient is responding and will respond on long term, yes, no, and at which level. So we are setting and designing this sort of test. Regarding the threshold to consider good response or not, for thalassemia intermedia, it's easy, because basically it's the hemoglobin level, but tuned with the individual patient, because we had patients that had, let's say, poor response. The hemoglobin jumped from 8 to 9 or 8.5. And so we were discussing and saying, okay, there is no interesting response. And the patient was saying, please don't take me out of the drug, because I'm feeling a lot better. So, but there is no time to enter the details on this. There are many reasons for that. So we wait the effect, and not just looking at the hemoglobin, other markers, hematological markers, but with the patient. And for transfusion-dependent patient, again, is the patient that I showed that is 40% less transfusional burden interesting or not? From the cost, by sure, yes. From again, is the patient points of view that is more important.
Thank you, Dr. Viprakshit. This is a question for you. Most patients with non-transfusion dependent thalassemia, at least in our part of the world, will be on hydroxyurea. So if they were to consider a trial of Reblozyl, should they come off hydroxyurea, or we should continue them along with that? Are you looking at doing studies with a combination of hydroxyurea and Reblozyl? Professor Viprakshit?
Yes, actually in the Beyond trial, the patients who been enrolled, they are not on the hydroxyurea, because we still don't know yet whether the drug will work or not. So that will be the subsequent study if you want to combine with the hydroxyurea. But so far at present, we don't have any data to show that is there any synergistic effect, or is there any possible interaction between hydrea and Reblozyl. Most of other patients that being enrolled in the study, they have to be off of the hydroxyurea before being enrolled. But I mean, most of the patients seem to respond well, even with the monotherapy with the Reblozyl. I got the patients who have baseline hemoglobin increase from 8 and up to 12 or 13, and we have to delay the dosing of the drug itself. So I mean, I think that remains to do the analysis, but I don't know whether who will sponsor that.
So I have a comment, additional comments, John Porter here. In the initial sotatercept study, we were allowed to keep people on hydroxyurea. So we had quite a lot of patients who were already on hydroxyurea, to which we added sotatercept, and you got an additional effect. Excellent. And they didn't get any drug interaction. So I think in principle, it's a good combination.
Thank you. The next question is to you, Professor Porter. Patients have asked, what, if they were to go for gene therapy, what is the approximate hospitalization or stay for gene therapy?
If it goes well, without complications, it could be 3 to 4 weeks. If there are complications, then it would be longer. But it's quite a short admission. It's notably shorter than an allogeneic transplant. The other thing that might keep people in hospital is persistent thrombocytopenia, if that's associated with bleeding. But the bleeding hasn't generally been an issue. Those are the things that might lead to a longer admission.
Thank you. Professor Piga, another question for you. The studies on Reblozyl have shown some meaningful reduction in serum ferritin. During the studies, what is the pathophysiology? What is the mechanism for that reduction? And do you feel that should be assessed as an additional advantage when assessing the efficacy of Reblozyl in a given patient?
Yes. Yes, there is some evidence that these happen in many of the patients on treatment. That is a better, let's say, to simplify, iron metabolism. That is, and in thalassemia intermedia, if the hemoglobin is going up, it's easy to think that there is more physiological, that is natural use of iron in the hemoglobin. So that is easy. But also in transfusion-dependent patients, there is this type of trend. So an improvement in the activity of bone marrow, yes, but there are possibly there are also other factors that are pushing to, let's say, a better management of iron in the body using luspatercept. Again, this is very different in different patients, but very interesting to be looked for, mainly in patients that needs iron chelation, that are on iron chelation.
And one last question again to you, Professor Piga. Is there any contraindication to giving a trial of Reblozyl or advising Reblozyl to a patient? Is there any condition or drug interaction or?
That is, let's say that a very important thrombophilia, that is a trend to have thrombosis, that is very important, is per se a contraindication. Or let's say contraindication in the treatment should be done very cautiously, using in example, a 3-month test very cautiously and strictly. And there is, I guess, no other full indication, but we have to learn a lot because we are studying the patients since years, but not in so many patients. So we have to learn a lot and now expanding the use.
That brings me.
And may I tell just that I have to leave this very interesting session because I have to enter another webinar now.
We're coming to a close, and thank you so much. I now hand over to, before Mrs. Tuli gives her vote of thanks, Dr. Soumya Santra, the voice of patient advocacy group. He was unfortunately cut off. Is it possible to give him 1 minute before Mrs. Tuli gives the final?
Yeah, he can.
So, Dr. Soumya,
he can finish his talk in just 1 or 2 minutes.
Dr. Soumya, please over to you so that you can conclude your presentation, which was unfortunately cut short.
Yeah.
Dr. Soumya, please go ahead.
Yeah, am I audible? Is my screen visible now?
Yeah, we can see you very well.
I think I am not able to share my screen now.
Just share your views and thoughts because,
Yeah. Actually, my views and thoughts regarding where I was stopped is that for us as thalassemic patients, what is safe blood counts for us is the blood that will give a good quality of life, and I can join my activities the next day, and it will not lead to any infections or any transmitted infections. Or even if I am requiring packed cell blood, I should have the accessibility for the packed cell blood. But because of the diversity of the political diversity and also the geographical diversities, we are not given that access all over the country to have all the parameters keeping in mind. Though we are talking about from bench to bedside, the many drugs are coming, luspatercept, and also the gene therapy is also there. So the cure is very near. But still, when you are talking about the care, that is the safe blood, which is the basic human rights for the patients, and not only thalassemics, but also dialysis patients and chemotherapy patients. These patients are all dependent on blood supply. So it is our earnest request from our TPAG's point of view that safe blood should be transfused and component separation should be available at all districts, and thalassemics should be looked after as not a monster of blood, but a safe blood for their life is to be ensured. And ultimately, I will end by saying that TPAG is looking after and working towards the policy working along with the policymakers and the influencers, so as to ensure the best of the blood supply, and also to supply during the crisis of blood during this COVID critical situations, pandemic situations also. So ultimately, I end by saying that we have been successful in taking the, you can say the belief of the social media and also the government and also the judiciary systems of the country, and to ensure a better future in regarding the safety of blood supply to our patients in the near future. Thank you.
Thank you, Dr. Soumya, for highlighting that.
Can you ask Mrs. Srivastava if she's there to give just 1 minute comment on this?
Yeah, thank you, Dr. Khanna. My only concern is that we are having the blood storage center guidelines coming in very soon, which will have an access to the red cells at the peripheral level. So you will find these guidelines within 2 months over it. Thank you.
Okay, thank you, madam. Thank you.
Thank you, Dr. Ms. Vinita, and thank you, Soumya, for highlighting that whilst we talk of the novel approaches, we have so much still to work at the grassroots. I now hand over to Mrs. Thuli to conclude this very interesting seminar.
Hello, everyone. Can you hear me? Can you hear me?
Very clearly.
Yes.
Very
okay.
clearly.
From home. But Dr. Michael, please convey my regards to her and a special thanks to her and to my colleague mentor, Mr. Chopra. Thank you for your inspiring addresses. Please join me in thanking Dr. V.K. Khanna, Dr. Amita Mahajan for moderating today's session so smoothly. We have nearly about more than 400 participants registered from 27 countries, but I think due to some technical problems, all were not able to connect to today's seminar. I appreciate your participation. Hope you all enjoyed the sessions and also learned a lot from the sessions. In conclusion, I would just like to make a few points. First, on the blood safety, let's all work hand in hand with policy makers, because they are the final authorities who are going to make changes in our countries, whichever country we live. TIF, blood institutions, never forget our doctors, hospitals, to ensure adequate, non-replaced, NAT-screened, pre-storage filtered blood for all our patients, whichever country we live in. Secondly, on the newer drugs, on Rebrozyl, you have heard a lot from our expert speakers. Once it is approved, my humble request to the company and to all the people who are involved in this, to make sure that it is available at affordable prices to our patients, especially in those countries where the treatment is not free of cost. Patients have to pay for their treatment. So if this drug comes, my humble request once again to all of you to make sure or to influence upon the company or the required or the concerned authorities that this drug should not be that expensive. It should not be beyond the reach of our patients. Lastly, on the gene therapy, as you have heard, that this is the future curative treatment, but is going to be quite expensive. So at this point of time, it's very difficult to say that is going to be available and what is going to be the final cost in developing countries. So please concentrate on your treatment, on your blood transfusion, follow our Indian guidelines, follow the TIF guidelines, or if you are living in other countries, if you have the national guidelines, please follow them and make sure that you are fit enough to receive this therapy once it is available in our countries. Thank you very much once again to all of you. Over to Tiff.
I think that Tiff has nothing more to say. Everything has been said. Thank you all for being here, and we look forward to repeating this and discussing frequently on the new developments. Thank you.